Kia ora everyone and welcome to this Goodfellow webinar on simplifying IBS, targeted management that isn't just FODMAPs. My name is Dr. Grace Lee. I'm a general practitioner for the Goodfellow Unit. Tonight I have the pleasure of introducing Dr. John Perry, who is a gastroenterologist based in Auckland. All right, over to you, John.
Thanks, Grace, and good evening, everyone. Look, I'm talking to you about IBS, something you all probably know a fair bit about. But this is my slant on things and how to hopefully simplify it and target it for you. So each of you knows something about IBS. You probably think of it as a bunch of symptoms to some extent, and it can go from constipation to diarrhea to stinky wind, brain fog, chronic fatigue, and you've all seen patients in tears, I'm sure. You've all been confused, you've all had a headache with it, and you've all decided it's a lot more than your 15-minute time slot as a GP. So that's probably still going to be true to some extent, although what I'm going to try and do is give you a framework. The reason it's so confusing now is because it's a syndrome. So, and there's the definition, characterized by chronic abdominal pain, altered bowel habits, and no organic cause, which sounds great, except that stamping someone with IBS doesn't mean a lot. There's so many different symptoms involved. There's a long list of them there, and there's no way that all these things can be one underlying cause. And therefore, there's no one management plan that's going to sort them out either. And that's the mistake that you can make, having one trick for everyone. So the way to get around this is to divide the patients up, and you can divide them into subtypes and then treat them accordingly. And the main subtypes we see are constipation predominant, diarrhea predominant, the alternators or alternating constipation, diarrhea. I add in bloating, whether they're bloating yes or no, on top of those three things. And using these subtypes, you can determine an initial management plan. But ultimately, if you can work out the underlying mechanism for the patient, then you can get absolute control of their symptoms and render them virtually symptom-free. So that's your ultimate goal. You can start off with the subtypes. An important message for this whole talk is that, look, all of the subtypes and all the symptoms can, in some patients, be constipation-driven, so look out for that. So how do I do it? And these are the kind of rules I use and break and change around, but from your point of view, it's a good place to start. So yes, divide them into subtypes, and that determines your initial management plan. A really important rule that a lot of people miss is to try easier things first. Low FODMAP diet, as you can tell from the talk, I'm not into it so much. It's very hard on the patients. There are a lot of easier things you can do first. And yes, some patients do require a low FODMAP diet, but you can pick off the things like low fiber diets and lactose intolerance first quite easily. And second, next rule down there was don't miss lactose intolerance because it's relatively straightforward but does hide. Occult constipation, as I've said before, can be the underlying cause in any symptom pattern. And the other thing to mention is don't diagnose IBS in older patients. Older patients don't generally seem to get IBS. They can get it, they can have had it for years, but generally they'll have diverticulosis, symptomatic diverticulosis, and the whole thing will be constipation driven, or there may be something more significant underlying. So you do need to investigate those patients before you can label them as IBS. My initial assessment is taking a history, which is far more important than any examination in this situation. And really I'll listen to their symptoms, but rather than them tell a story, I'll try and target it a bit and ask them whether they're having constipation, whether they're having diarrhea, how often each is happening, particularly whether they've got bloating present. So I'm after the subtype and how long it's been going on for. I do take a dietary history. If there's any dietitians out there, mine's horribly brief. And I don't go through the pages of the diet and what they've eaten for the last month that they might bring along. I just want a summary. And the summary I get is, what do you typically have for breakfast? What do you typically have for lunch? What do you typically have for dinner? And I'm really, yes, I'm listening to the food groups and I'll write them down, but I'm more interested in how much insoluble fiber there may be. If they're having muesli with Vogel's bread, things like that are easy things to pick off. Too much fruit is another one, alcohol. And you're looking for dairy in large amounts and whether that seems to follow with the symptoms. Things like sorbitol, fizzy drinks, gum, they're fine print, they're pretty rare. You guys are all GPs, so hopefully you're all good at looking for alarm symptoms because it's very important. And so obviously bleeding is an issue in older patients with new symptoms, nocturnal symptoms, incontinence, and progressive pain that's getting worse. Those patients need investigation. And again, the same for people with significant family history. The as far as medications go, I'm interested in medications that alter the bowel, constipating, or medications that cause loose bowels. When it comes to investigations, everyone's pretty good at doing standard stuff. CRP's been around forever, celiac antibodies, everyone does those, thyroid function. Calcium I often get to add. You've got to be able to think of one other thing if they come see a specialist for a blood test, but it really is associated with constipation incredibly rarely. Stool specs usually get done well as well. Someone will have looked for bugs at some point, and I think most of you are getting the idea that fecal calprotectin is quite a big player in this situation. It's not always used well though, so I'll put a little bit of info about that. I think fecal calprotectin, if you think of it like CRP for the gut, calprotectin is a protein that's produced by neutrophil granulations. It's actually produced in loads of other fluids, spinal cord fluid, lots of other places, but the stool is where it's found. It's niche. It's stable, so it can sit in the poo pot for 24 hours before it goes to the lab if you really want at room temperature. But the important point is that it'll go up with anything. Think of it just like CRP, it'll go up like anything. So just like you wouldn't bother doing CRP if someone had a runny nose and a cold, because it's going to be elevated. If they've got gastroenteritis, you do check the calprotectin, yeah, it'll be elevated. It's just any inflammation. So it doesn't matter. It doesn't mean they've got Crohn's disease. It's not a marker for inflammatory bowel disease. It's a marker for anything going on, anything inflammatory going on. It'll go up and go down with acute stuff. So it's really useful only in chronic symptoms. And that's your screening for inflammatory bowel disease, basically. It's more sensitive for distal things going on rather than proximal. So small bowel Crohn's might put it up to 90 or 120. An anal fissure will put it up to 3,000 sometimes. So it doesn't mean Crohn's disease. It means it's inflammation, and it's very high. It may mean the inflammation is right at your bottom. Now, I will use cases to go through. I've changed the offensive photos of the politicians. So hopefully, I don't know who in the country is watching this. So sorry, that's clip out. Look, this first one's a 35-year-old woman, a typical sort of patient with abdominal pain occurring after meals, central lower abdominal pain, and relief with defecation, as you expect for some people with IBS. Her bowels are open every third day, and it's been that way for 6 years since she had her last baby. Doesn't get bloating, but does get some constipated symptoms of incomplete evacuation and straining, but it'll look bright red blood if she passes a hard rock. And her diet's fairly unremarkable. I think you can work out that the subtype's probably going to be constipation predominant. And likewise, you can work out the things you do for constipation because you deal with that a lot. I didn't put extra 6 glasses of water a day in there, but the standard things you do for patients who are constipated, and usually they shouldn't have made it to my clinic without trying high fiber foods. You get the occasional student who's lived on pies, but basically it's, they've usually done all that. And you know that basically you can give laxatives and you can have high fiber diet for patients who are constipated. Slight difference with IBS we'll get to. So a bit on laxative use, I better say that, because when you find these constipated patients, sometimes the most important thing you can do is reassure them they can take laxatives. The whole laxatives causing a lazy bowel thing has changed. Hopefully you know which laxatives of these you can give regularly. That's a trick question. You can give any of them. Stimulant laxatives don't cause a lazy bowel. There's one of the various references down the bottom there that came out around 2003 when it was all disproven. The problem is that there've been many generations of us saying that laxatives cause a lazy bowel because of some professor generations ago who decided it. And now that it's been disproven, it's going to take a whole generation for this information to leave. So it's still written on the bottles of the Senecot. It's still told to the patients by the pharmacists. It's still all over the internet. But if someone needs to take laxatives regularly to be comfortable, they're not doing themselves any harm. If they're taking laxatives to abuse them, to cause diarrhea, to lose weight, yes, they'll have a problem. They may have various issues, including prolapse later in life. So it's not a clever thing to do. But as far as your constipated patients who are desperately avoiding the laxatives because they feel guilty, sometimes just telling them that is life-changing. What I usually do though is I'll use the laxatives to get things going, and then I switch things to dietary stuff. So wheat prunes, kiwi fruit, psyllium, ground linseeds. I quite like that flowy supplement because it's a capsule, whereas the kiwi fruit go off. Sometimes they cost $1. But there are various ways of doing it to get some increased fiber. And then you can use the Laxol or whatever laxative as required. The tablet ones patients quite like because they're easy. Metamucil and psyllium is quite chewy. The important other point is that one thing isn't the same in everyone. So one person's rocket fuel is another person's dud. I've seen patients who can't take more than one prune, or they have horrendous diarrhea. And other patients can have bisacodyl and notice nothing. So it's really important to try some other things if they say, oh, these don't work. When they're really full up, when they're really constipated, then you can sometimes have to go a bit more drastic. And look, I'm an interventionist, so I'll use bowel prep sometimes. I'll tell you a bit more about that later in the talk. So if the laxatives are successful, like I say, you can backtrack to dietary stuff. You've proven the point, now you just got to keep things moving. So this patient, though, wasn't just constipated. We got things going with prunes and Senecot as required, and got everything going without the straining, regular soft motions, but the abdominal pain persists. So she's still got some visceral pain despite shifting the constipation. Now, visceral pain can have a number of possible causes, but you know that there are some treatments. I don't usually hand out pills to patients dealing with IBS. I'm looking for other ways of dealing with it, but sometimes you do need to damp down unnecessary signals from the gut. Antispasmodics are your classic ones. Colofac is the safest one to use because it's it doesn't cause constipation, which buscopan does. So buscopan, if you take it regularly, causes constipation, defeats the whole thing. Colofac does it, it's great if it works, but a lot of people it doesn't work in. So, and there are some other ones too, again, trial and error. You've probably all tried tricyclics at some stage. SSRIs are probably less effective, but are an option. They do help move the bowels too. For God's sake, don't start anyone on opiate analgesics with IBS. They never get off it. If you give someone with IBS and abdominal pain morphine, yeah, they feel great. And it's a slippery slope that just carries on because it constipates them more. Helps treat your pain, and then they can't see a way around it. You have to try and solve the underlying mechanism if you can. I haven't seen that as much actually. There haven't been as many patients with IBS on opiates, but there was a stage I remember as a registrar where some of them were having pethidine and God knows what. Tricyclics are the best for visceral hypersensitivity. You're all used to the sales pitch where you tell them it's a very low dose compared to the antidepressant dose, and so they usually manage it. Some may get a hangover in the morning and can't take it. SSRIs are a harder sell because, you know more than me, it's hard to get patients off them once they're on. It's quite a rocky road to get off. But they can be useful for constipation, predominant symptoms, particularly with a lot of bloating. Some severe cases of post-infectious IBS, they can be useful. They're not as good for pain control though. The next case is 50-year-old housewife.
John, can we just do a few questions before we move on to case number 2?
Go.
Now, just sort of looking at things on the constipation side with regards to medications, you alluded to being able to use stimulant medications on a regular basis. Now, are you talking about being able to use this every day, or would you suggest using it intermittently?
Well, you don't have to use it every day, and obviously you're going to try and do things naturally and use it intermittently, but you can take Senecot every day safely. Okay. And that's what those papers were looking at.
Great.
So it's a total turnaround from what we were told at medical school. But they're not doing it at medical school anymore, you'll be pleased to hear.
Now, with regards to advising other forms of constipation relief, like glycerol suppositories, Microlax, or home enemas, are we able to use these on a regular basis, or do you suggest more caution?
You can use those. Fleet enemas are a bit rough if they're too often. Some patients, you're probably talking more about obstructed defecation now, the ones that use the suppositories. I haven't really gone into that in this talk. You occasionally do get patients with IBS that actually just need to see the pelvic floor physio because they've got dyssynergy and obstructed defecation. That's a harder one to find. I know the pattern to recognise now, but I can tell you what it is. You can give them bisacodyl and everything and gurgle or nothing comes out. You keep giving them laxatives and their tummy sort of gurgles, but they can only ever pass liquid stools. And those patients may have, and they can't pass formed things, those patients may benefit from pelvic floor physio. And if you get the ones that are using the Microlax all the time, it's maybe where they should head. There are investigations you can do to prove that. There is actually a rectal exam you can do. The surgeons do it, they taught me, okay, so look, you're all used to PRs looking for prostates. The difference between a colorectal surgeon doing a PR and a gastroenterologist that turned out doing a PR was that they obviously have to sweep around and feel the muscle there. But then they'll ask the patient to squeeze, which we're all good at doing. Then they'll ask the patient to expel their finger while it's in there. And if they've got synergy, then the patient will grip their finger when they're trying to push. So rather than they'll feel the sphincter grip when the abdomen's pushing. So in other words, nothing will get out, because when you're squeezing, you're actually closing at the same time. That's what the synergy is. Anyway, I digress. Carry on.
With regards to Colofac, is this best used in short bursts, for example, a few weeks, or do some people just need it long term?
Conflicting stories on that. I'll tell people to try it for a week or two, and if they don't do anything by that point, throw them away. 50% of patients seem to benefit from them. You can, if you've worked out if you're not sure, then you can have a couple of weeks on, couple of weeks off. So I do give them at least a couple of weeks trial before giving up on them, but I'll definitely give up on them. You don't have blind faith in those pills.
Okay. Now, I'm probably going to pronounce this horribly. It's a medication I don't use. Can you use mebivarine? Probably pronounce that wrong.
It is Colofac.
Okay, that's Colofac. Well, there you go. There's the answer. Thank you. Now, just one last one before we move on. Backtrack into the testing. Now, calcium testing.
Oh, look,
someone wants to know
that's probably
what we're looking for.
So elevated calcium causes constipation. So if you've got a constipated patient, it's part of the screen. Celiac disease can cause constipation. Thyroid, everyone knows that hypothyroidism can, but hypercalcemia can as well. So that gets thrown in. That's all. It's not a biggie. It's a fine print issue. Okay. Probably found 3.
I think you'll probably expand on this a little bit later on, but there, just to sort of seed it in your mind, when you talk about low fibre diets, how do you measure this against a healthy heart diet?
I'll definitely be expanding on that.
Okay, great. All right, that's it for now. Thank you.
Cool. So the next case is having abdominal pain most days, down in the right iliac fossa, central, postprandial, pre and post defecation. Has been constipated for 20 years. The bowels open twice per week. When she takes laxatives, she gets belching, bloating, her weight's increasing. She has an excellent dietary fibre content, and still she's miserable. So again, we've got a constipated patient, but this one's got wind and bloating. The management can change. Now, these are not hard, fast rules, okay? But some of these patients, the more fibre you give them, the worse and more miserable they are. And that's your constipation prominent IBS with bloating. Don't give them high fibre. You can switch them to low fibre. Some of them will actually benefit significantly from that, because it's cool. For some reason, without the insoluble fibre, they don't get all the bloat and their bowels move normally. Now, that's not everyone. So often these patients will still need something to move the bowels, but cutting the fibre down will actually make them comfortable as well. Some of these patients can benefit with a small tick on the low FODMAP diet. It's something, it doesn't mean it never works. It's just something to consider later down the algorithm. These patients are the ones you give the Metamucil to, and they won't like you. And whenever you're giving Metamucil, you always warn patients it may cause pain if it does stop, because otherwise you break that kind of contract and they'll find someone else, which may be a good thing depending on how much you like IBS. I don't want them to go anywhere else. So yeah. Talking about fibre now, Grace says yes. So it can cause bloating in IBS patients. For your standard person, Vogel's bread is lovely, okay? But for your IBS patients, it can be a killer sometimes. It can cause pain, wind, and it can cause diarrhea too in some of them. And it's mostly, if you get into the details, it's the insoluble fibre component that leads to it. The going on a low fibre diet, unlike a low FODMAP diet, it's very easy and quick. So you can just do it for a week or 2 weeks if you're not sure. You have to, the problem catch to it is that they might become constipated while on it. So you need to remove the dietary fibre while keeping the bowels moving. It's not a forever diet. This is to see whether fibre is causing the problem. So basically you go fully low fibre for a week or maybe 2. You give them some Laxol so they can move their bowels, because they become constipated, the whole symptoms may increase anyway, and you won't learn anything. And then if this works, you can then go to a modified fibre diet, which is something the dietitians often get involved in. But basically patients, if they're doing the DIY version and can't afford a dietitian, it's just negotiating. They go to low fibre and they no longer have the pain, well, they know fibre was causing the pain. Then they can look at how much fibre they were having and moderate it. But if they start negotiating at the beginning, they'll never get it right. So the I'll go to the high and low fibre list in a minute. So fibre is a good thing to look for, okay? It's a worthwhile thing to pick off. All the patients know that high fibre should be good for them, but a bunch of them, it's low fibre is what they need. So for bloating though, is a relatively difficult symptom in some patients. Some it's as easy as constipation, some it's reflux, lactose intolerance, this fibre thing I was talking about. Some will have FODMAP intolerances, there's disaccharidase intolerance as well, which is in the fine print further. Some of them are just overweight. But that's just to remember that the bloating can have a number of different reasons there, and some of them are very easy. There's some high fibre foods, and it's everything you love, all these whole grain things, and we've been, brainwashed. It's not a terrible brainwashing, but we've all been programmed over the years that these are the healthy things, with the low GI index. Originally, the high fibre foods were fit to prevent bowel cancer, and then the more and more studies came out showing that fibre probably had nothing to do with bowel cancer, but by then we'd all bought into it and changed our lives. And it turns out it's probably a lot of them are good for heart disease and things as well. They're the low fibre diets, but you can take one look down there and you see various forms of white death, right? But it's not a permanent thing. It's just for a week to see whether that's the issue. And then once you've worked out over a week, over that was the deal, you can then flick back and forth and say, we're going to have a certain amount of this and a certain amount of that. But I do see some patients that are just crazy with their brown rice, whole meal, this, everything's natural, healthy, rabbit food, and it's causing them terrible bloat. And so you've got to try and say, look, just for 1 week, you can eat like a child would love to. And then you go back to half of what you did probably. That's where we're at so far. Constipation predominant, the two kind of versions of it, with and without winded bloating. And it does vary with the fibre stuff predominantly. You do have to consider though, what proportion of this is just constipation. Some patients the whole thing may be constipation. They may have a myriad of other symptoms like bloating, brain fog, and everything else associated, but it's all just driven by constipation. I'll tell you that again in a moment. So the next case has the alternating symptoms, constipation, diarrhea for 3 years. No bowels. Typically, this is what the story you'll get. Nothing happens for 2 or 3 days, and then they have a terrible day of abdominal pain and diarrhea going 3 or 4 times. Might be housebound on those days, might need diastop, it's wrecking their lives. And this is your classic kind of story of the alternating constipation and diarrhea, although it's not always as perfect as that, flipping back and forth. How you're going to manage these patients is the tricky part. They are different. Again, one of the issues though is that this condition is driven by the constipation. They come in saying they've got a diarrhea problem, but the issue is actually that they're constipated and then it releases as diarrhea. They usually don't benefit from the high fibre stuff though, because it's very easy to do and those patients have all moved on. They've got proper IBS and so they're intolerant to certain things. Maybe fibre, there may be other things, even FODMAPs that may be causing the issue. One of the interesting things about them though is if you can prevent the constipation, then you can prevent the diarrhea. So you end up giving them laxatives to avoid diarrhea, which doesn't make any sense whatsoever. And that's a harder sell for patients, and sometimes you'll need to find ways to prove it for them. So constipation is the underlying cause, but they think they've got a diarrhea problem, and that's the difficulty. Sometimes you need an abdominal X-ray to prove it. You should time that just after they've had their diarrhea day so that they think they can't possibly have anything in there, and then they'll have a bowel that's 2/3 full still. And that's one way I get them to do it. I do a lot of my IBS in private, but when I see patients in a public clinic where I do a lot of liver disease in public now just because the way things got shifted around. But I'll often send patients for an abdominal X-ray, bring them back in and look at it electronically with them and say, look, here you are constipated, But it's only really useful if they don't believe they're constipated. So you manage these patients as if they're constipated. You get their bowels moving, but you're going to actually have to look for things like fibre or possibly FODMAP intolerances as well. The main thing, this first place to start though, is getting their bowels moving. Prevent the constipation, you prevent the diarrhea. And all the other things can be used. That pattern also can be mimicked by lactose intolerance. If they're having dairy intermittently, they'll get diarrhea intermittently. So that's where we're at the moment with the 3. And again, that one probably does better with the low fibre than the high fibre. Again, constipation is probably driving it, but what proportion of it may be is an important question to answer. I mentioned the abdominal X-ray. Don't bother using it if the patient says they're constipated. If they're constipated, you know, it's fine, okay? But if they don't think they're constipated and they've got abdominal symptoms, it's very useful. If they say my bowels are working every day and then at an X-ray and it's totally full up like the ones I've shown you, then I don't know how well it projects on small screens, but then you've got a disconnect there. And that's often, there are patients that go every day, but they don't, you think, if each day you go to the toilet, but you don't go as much as you've made, then over time you will back up and there'll be a jam. So, and for patients, particularly with diarrhea, if they've got regular diarrhea and you do an X-ray and they're full up, then they don't have a diarrhea problem, they've got a constipation problem, but that's presenting as diarrhea. So the X-ray is very useful, and it might mean that you then go to trial laxatives as the next step, or even bowel prep, which I'm a big fan of. And then after you've succeeded in proving the point, you then can do it with dietary modification. So you be interventional to prove the point, and then you switch back to mild stuff. There is a couple of provisos to this. You can't trust the radiologist here. My brother's a radiologist. His historical, they are blind to poos. He's a pediatric radiologist. He's allowed to comment on fecal loading. Adult radiologists will only do it if you twist their arm. That's because radiologists in general don't like talking to patients and having negative feedback. And if they write this patient is constipated, the not constipated patient will then argue with them. That means talking to them. It's terrible. So they'd rather sit there in the dark room and look at the films. So, but you can get around this, okay? Don't write, is this patient constipated? Say their symptoms, and then say, do they have proximal fecal loading or significantly low? Actually, don't say significantly, because again, their idea of significant is a megacolon, because it's the way they've been trained. So you want to say, is there proximal loading, something along those lines, and then they'll answer the question. At least on the North Shore in Auckland, I've gradually trained them all up to answer that question. The next case is a 60-year-old man, and he's had 7 years of loose bowels going 5 times a day with just some nocturnal symptoms, but basically gets a little bit of discomfort. His bowels open frequently, they're loose, he's otherwise fine, weight stable, nothing to concern about, getting on with life, using a bit of diastop if he's going out walking. So this could be diarrhea predominant IBS, depending on how you read it. IBS is a funny thing, and when diarrhea predominant IBS is incredibly rare. It is seen post-infectiously, okay, so down in Hastings, when they had a water supply poison, they would have had loads of IBS, post-infectious IBS afterwards. A lot of that is diarrhea predominant. But for patients like this that have been going many years with loose bowels, they usually have chronic diarrhea. And so don't be in a hurry to diagnose diarrhea predominant IBS. And usually I will find a physiological mechanism underlying this, which I can turn off like a tap. So, and you know, it's closer to 100% really that you can sort out that way. So if you have patients with loose bowels, or chronic loose bowels, then with a bit of investigation from a gastroenterologist, they should be able to switch it off. If they can't, I can have a go, but you know, they can be sorted out. So they need further investigation. The thing you can do though as a GP is obviously screen for things like celiac disease and do fecal calprotectin for inflammatory bowel disease, but you can try and treat them as if they're diarrhea predominant IBS by giving them a trial of a low fibre diet. You can cut down on their fruit, avoiding excess caffeine and alcohol. They might very occasionally be that one that's having all the sorbitol. But that's one thing you do. The other thing you can do is an abdominal X-ray. As I mentioned, these patients with chronic diarrhea, a lot of them they're actually constipated. And the trick will be that they'll have bloating associated with it and smelly wind. The smelly wind going on, lactose intolerance and constipation are the two kind of things to immediately think of. So it's worth doing an X-ray, because if the radiologist admits that they're loaded throughout the colon and they're telling you they've got chronic diarrhea, then it's obviously a disconnect, and it's one for the bowel prep to prove it. But these patients, look, diarrhea predominant ones, do send them through to specialist help because they can be sorted out. Who does need investigation is another question. Look, everything's on its merit, obviously, but persistent new symptoms for older patients particularly, it's important. I mentioned alarm symptoms. Those with a significant family history, it's important. And if any of those tests are suggesting you look further with anemia or raised calprotectin, obviously I didn't tell you about positive immunochemistry stool tests, but all these things are reasons to look. Diarrhea predominant patients, they're worth doing investigations too, because particularly in the older patients, microscopic colitis is quite common as a standard cause and a treatable cause. In private practice, where I see a lot of my IBS patients, a lot of them want reassurance. I don't push it on them, but a lot of people come wanting to have a colonoscopy, and I think out there in the general world, when people have got significant gut symptoms, they want to know there's nothing there, there's nothing blocked, and it's relatively easy. They've got private insurance anyway. If they have loose bowels or bloating predominant symptoms, then I'll tend to do a gastroscopy as well, because we get duodenal biopsies to rule out the 5% of celiac disease that's missed with the antibodies, and also to get biopsies for disaccharidase levels, which are enzymes to do with different sugars, picks up lactose intolerance as well as sucrose and maltose. I mentioned the bowel prep. Look, I think it's a fantastic tool to diagnose these patients. I've mentioned that so many of them are just constipated. The proof comes after the bowel prep, because if you give them some Laxol and they go a couple more times and think, unless you did an X-ray to see what's actually there, you don't know how empty they're getting. Whereas bowel prep, you know exactly how empty they're getting. And so if I see a patient who turns up as an open access colonoscopy and I talk to them, they're having abdominal symptoms and bloating, there's a window of opportunity then to decide whether their symptoms are driven by constipation or not. And if you're not in my area and don't want to send them to me privately and you send them somewhere else, and I'm sorry, but there are people all over the country who will give them reassurance that there's no cancer and send them on their way, or to a dietitian who give them a low FODMAP diet. Tell your patient, prep them when they're going for their colonoscopy, that they should take note of what happens in the probably 3 or 4 to 5 days afterwards, because they're going to be empty the following day. And patients only take note when they get symptomatic. They take note when they're uncomfortable and when they're miserable. When they haven't got their symptoms, they get on with their day and they think about other things. So get them to take note at the end of each day, not the first day of the procedure, but the next 3 days or 4 or 5. If they were constipated when they went in, you want to see after they've been cleared out, does all their bloating go away? Does their brain fog go away? Do they have more energy? Is there chronic fatigue? All these sorts of things. You ask them specifically what their symptoms were that you're sending them for the procedure for, and ask them whether those symptoms were present on the days that follow. If they have chronic diarrhea, you really want to know how many days it takes till the diarrhea returns. Patients who have all these problems and then have normal stools for a week afterwards before they go back to their previous pattern, then they have a constipation-driven issue, and it had to build up again before the issue started again. Those that have diarrhea the first day after the colonoscopy and continue having diarrhea, they've got chronic diarrhea, so they need to be investigated as such. And those where the bloating is entirely gone, then the bloating was driven by constipation. So it's an important kind of, if you achieve nirvana in the days after the glycoprep, then they have to remember how that felt, and then you have to find a way to keep them that way. Obviously, you can't have glycoprep every other week, but when you are doing that, then you can learn a lot from it. But if you don't pay attention, you'll miss that opportunity. And they need to write it in their phone, because if they had a constipation-driven problem, it'll go away. So they probably won't come back for the follow-up. We get them to write down what happened in their phone so that they won't make it up when they're talking to you. Oh, I think I was da-da-da-da. It's kind of, and so I'll always get people to do this and take note, and that's gold at that moment. That will send you in different directions depending on what happens in the days after the bowel prep. So if a patient's not having a colonoscopy, I mentioned I'm a interventionist, I will give them the bowel prep as if they were having it, even though there's no colonoscopy happening. If it will give me a black and white answer, yes or no, is this constipation driven or not, and then I'll move on and forget about it after that, or I'll chase that further. So whereas other things you do, bit of prunes, bit of kiwi fruit, you'll never know whether you did enough. That's just the way I see it. So, but then of course I hand out bowel prep for a job. So, By the way, if you are taking bowel prep, for those of you having colonoscopies, barley sugar is fantastic. You can scale the thing back. It tastes average if you taste it. Don't taste it. Knock it back very quickly. Barley sugar in your mouth as it leaves your mouth, okay, so that you don't actually taste it. I had mine. It tasted like barley sugar, so I don't even know what that black root tastes like. So you look after the other end with some wipes as well, but you can work that out. Now, a word I should say on lactose intolerance. Look, classically, lactose intolerance is easy, right? It's cramps, explosive diarrhea, 15 to 60 minutes after, maybe 2 hours after having some spell checked my diarrhea there, after having some milk. But the reality is that if you've got a constipated patient, they may never see the diarrhea. They may just get the bloating. That bloating is methane, so it's smelly. So all they may get is just some smelly wind days later. Some patients, we're all just different, okay? So the classic lactose intolerance, the patient often works it out themselves, but some patients have lactose intolerance. Some will just have chronic diarrhea without bloating, without smelly wind. It's funny, I've seen people that have done the Mayo Clinic and been fully investigated, found their way. I was about the 5th doctor, and I just checked the disaccharidase levels on the gastroscopy, and the patient was lactose intolerant. How come that hadn't been worked out already? I have no idea. Many thousands of dollars later, but that was the problem. Patients become lactose intolerant, and if obviously Asian, many patients from Africa and all that, they'll basically get lactose intolerance as they get older, and it's often a cultural thing, and they'll know it. But it happens to people from all ethnic backgrounds as well. It can be you can get it after post-Giardia or post other gastroenteritis. You can have decreased levels of disaccharidase enzymes, and so it can come on as a post-infectious thing. It's worth a try. All you need to do is 1 week of being dairy-free to work it out or not, and that'll solve the problem.
How common is it?
Oh, it's incredibly common. It depends on race, really. So in Asian patients, it's very, very common. It gets up to 90% in some cultures. And it's age-related, so it's genetic. So it goes up. It's a genetic loss over time. So patients can start off lactose tolerant and become lactose intolerant later in life. Whereas other people can get it out post gastroenteritis or post some injury to the gut. If they're having intermittent symptoms and you're not sure, then I say on your Saturday, go home and drink a full glass of milk. And if that causes the symptoms, it's quite conclusive. I don't know how many of you know about lactase capsules. Probably not as many as should do, because I keep finding patients with lactose intolerance who've never heard of them. Lactase capsules are fully available on the internet or in pharmacies, and they just make you bulletproof. So you can try the glass of milk challenge, cause the symptoms. You can do the same glass of milk challenge with the lactase capsule and prove that it blocks it. It doesn't mean you need to use them all the time. Obviously, you can solve this problem by limiting your dairy. It's not an allergy. It's you know the physiology, and really small amounts of lactose won't cause it. Bigger hits will. Big latte will. And you could just have the lactase capsules for that thing you love, or more importantly, you could have it when you're eating out, or when you go visiting a friend and they've made this cheesy something for you, and you don't want to be that person who's lactose intolerant. You can block it. It's a shame we haven't got the same thing for celiac disease, but it does mean that you can just go out and do stuff. The classic places where these patients get hit is when they're out to dinner. Chefs reduce cream into sauces, so if it tastes nice, it's probably got cream in it.
Now, is lactose intolerance intermittent or a permanent thing?
So you can have lactose intolerance after an infection. So gastroenteritis can bring it on, and then the brushboard enzymes can grow back. And so not everyone with Giardia is going to end up permanently lactose intolerant. And there are varying degrees. We measure lactase, and the normal is between 2 and 8. And some patients will have minuscule amounts like 0.3. Others will be 1.8 and almost within the normal range. And so they'll only get hit by larger amounts. It's all about matching the amount of enzymes you've got to the amount of dairy you're having. So a patient with lactose intolerance could drink a 2-litre bottle of milk if they sipped it throughout the day and just trickled it past. It's kind of like that. And it'll vary depending on how much enzymes they have. But yeah, someone post-infectious gastroenteritis can sometimes be driven by this. So it's worth cutting down on dairy in that situation. I mean, as you tell patients with acute gastroenteritis. But once they've got it, no, they're stuck with it.
Thank you.
FODMAP diets I was bagging, I look, it's very well researched and there's a lot of information about it, okay? And basically a low FODMAP diet is taking everything bloating out of the diet, and then when it's done correctly, what's supposed to happen is the dietitian supervises it, that you take all the FODMAP containing foods out and then you reintroduce them one by one as a challenge to see what is causing symptoms or not. And you know, that makes a lot of sense, and there is good basis for it. The problem is it shouldn't be used on everyone, because if your underlying problem is constipation, then you often have FODMAP intolerances while your bowel is full, and when you flush them out, they're either not there or they're minimal. And so you can go weeks or months on this miserable diet, and significantly, some of the constipation with bloating can go on the low FODMAP diet, and it will decrease their symptoms, but they won't get full control. And they'll always be searching for that other thing in their diet which is causing their residual symptoms. Then what they needed was a big flush, and then they wouldn't have needed the diet in the first place. Okay? So you can send someone in a miserable kind of purgatory round in circles where they're going to suffer for a long time. I don't know if any of you have tried this, but it's very restrictive. And it should, to be done right, it's done in the hands of the dietitian. But someone needs to do an abdominal x-ray first. The same thing goes for breath tests, looking at FODMAP gases. They will have a 50 to 70% false positive rate if the patient is fecally loaded. So who does the x-ray before they do the breath test? That's what you want to know. Because breath tests are fully available and not just doctors doing them. So, but you know, whether they'll actually look into this, it's a terrible, a good study showing that terrible statistic. And it's what I found when a very respected, and you know, one of my mentors who was very into FODMAP intolerances, when he retired, a lot of his patients then switched over to me. I found you know, his patients were, I can't eat this and I can't eat that and I can't eat that. And I did an abdominal x-ray and I thought, oh dear, you know, flushed them out, and then they're like, it's better, you know. So you need to look at other things before FODMAPs is the answer. FODMAP diets are useful, low FODMAP diets are useful, dietitians are excellent, but you need to exclude the occult constipation first before you get involved down that alley. Gluten-free is another one that's done, and probably it's done usually before the low FODMAP diet, although it's included in. A lot of people will be, if they see naturopath, will be told go dairy and gluten-free. It just seems to be a standard dairy and gluten-free, dairy and gluten-free. I think you need to separate those two. Okay, if you're going to go dairy-free for a while, see if that makes a difference. You don't want to take things away from people when they don't need it. And so a trial of going gluten-free is another thing to consider. These, the low FODMAP diet, though, does have evidence backing it up. And as I said, it can put patients through a lot when they didn't necessarily need it. And if you don't watch it, patients will stay on it forever because they never found the full resolution of their symptoms. So they're just doing it themselves and they just keep taking things away. You find these patients who think they can't take anything. And my job is to convince them otherwise. But you've got to fix the symptoms first, though. So, it's exactly on 45 minutes, Grace. Okay, there's a take-home messages. Look, definitely do the basics right. Work out what subtype they are. Do the dietary history briefly, and obviously look for alarm symptoms. Divide them into subtypes, and that'll aside your initial management, but won't necessarily be the final result. Do the easy things first. So if you're seeing your 15-minute consultation, work out their subtype, give them something to take away and try, and say, come back and we'll work through some other things. It'll probably take 20 minutes. Remember, though, that all these patients can be constipation driven, even the ones with diarrhea. And so consider an abdominal x-ray to write the right things on it. The bowel prep, look, if they're going for the colonoscopy, hopefully at our fine white matter endoscopy, get them to pay attention afterwards, okay? Get them, if you know, using the bowel prep, or if you're getting a colonoscopy for a patient, get them to pay attention to the symptoms. They won't necessarily be told to them to watch that afterwards. It's kind of getting the word out, but often that won't be mentioned at all. They'll get the colonoscopy and be sent to you with a report. So those are the subtypes and what to do with them, just as sort of a summary slide. And really, you're only going to try high fiber on the constipation predominant ones. You may end up using increasing fiber for certain things, not diarrhea predominant symptoms, but it's not a place to start. Start with a low fiber because it's quick, it's low hanging fruit, it's easy. Just 1 week while keeping the bowels moving can sort out some of the other things. And then, as mentioned, look, I do work at the hospital, North Shore Hospital. We also work in private, Waitemata gastroenterology and Waitemata endoscopy, which will look after your patients. Fantastic.
Great. Well, we've got plenty of time for questions, so if you have questions out there in the audience, please type them in. Now, I'll start off with some of the questions that we have on our screen tonight. Now, with regards to, do you mind just backtracking a little bit on the slide before?
Yeah.
Just so we can go over the low fibre diet. This is something which is a little bit new for a lot of us. So do you mind just giving us that general understanding again of why low fibre?
Yeah, so the details, what we're actually looking at, it's a surrogate for soluble versus insoluble fibre.
Okay.
So insoluble fibre is stuff that would usually turn up in the stool. Things like onions, tomato skins, things that can in some patients, not in everyone, because we're having these foods all the time, it's not making us bloat, but in some patients it can trigger the bloating. So by going on a low fibre diet, it's not a permanent change. What it's doing is taking out the insoluble fibre out of the diet for a week to see what happens, a week or two to see what happens. And if that has a dramatic effect on people's symptoms, then you've got to look at this and say, well, they're going to get overweight, they're going to have coronary artery disease, all these other issues associated with this. This is not a permanent diet, okay? This is a brief trial, and then you're going to negotiate backwards and say, well, actually, I loved some of these foods, but now perhaps I didn't need to have everything whole grain, everything brown rice, everything, which some patients do. And heaps of people out there are doing this without any symptoms whatsoever. But in a patient with IBS, you've got to look at what is the mechanism, and some of them are fibre intolerant. The really difficult ones actually are the vegetarians in this situation. So a vegetarian who's fibre intolerant, I call them the experts, get the dietitians involved. I haven't had too many vegans come visit, but that's a nightmare as well. But then you have to actually look specifically at soluble versus insoluble fibre, which is what the surrogate is. So a modified fibre diet, which is the official thing that they can go on, is having more soluble fibre, which is the easy to digest stuff, and less of the insoluble fibre. I didn't tell it to you like that because you blank over, some people blank over, and it's better just to look at the high and low fibre because it's just a screen, and then you are negotiating, and you drift back to the things you love, knowing and that feel healthy, knowing that too much of them will be causing the problem. And patients, so they can end up patients should never stay on a strict low fibre diet forever. It's not good nutrition. Okay.
A lot of what we do in general practice with irritable bowel is to educate, and sometimes it feels quite difficult to educate well, to be quite frank, particularly when symptoms seem quite opposite. You've got constipation and diarrhea and sometimes all mixed together. How do you approach this?
I guess as part of coming to specialists, they're more likely to hopefully listen and at least try what I've told them. How do I do it? Is not so much educating. The first thing I want to do is solve the problem. So if someone comes to me with IBS symptoms, I want to get rid of all those symptoms, find the mechanisms underlying it, and render them symptoms or a whole lot better than when they walked in the door. If you can find the mechanism, then you'll be able to sort it out. And so I guess I don't like reassuring people with IBS. I like solving their problem. You can get reassurance all over town. You can have a colonoscopy, you haven't got cancer, good on you go. You've got a functional problem, read these brochures. But it's far more important to work out the mechanism, solve the problem, minimize their symptoms, and then you can educate them how to avoid the symptoms in the future. IBS is a functional problem, so therefore it's not going to kill you, but there's a lot of misery out there. A lot of people that have just been told, well, you're reassured you've got IBS, but they're quite miserable. So I think the important thing is to sort of work out the thing underlying it and minimize the symptoms that way, and then that's the best way to solve it.
So with regards to some of those symptoms which are less gut focused, so we talk about stress, we talk about brain fog, how common are they, and how do you counsel your patients around those sorts of symptoms?
So I'll start with brain fog, because brain fog is an interesting one. It's there are a lot of conflicting bits of information out there, so I've learnt as I've gone. With brain fog, there are a couple of things that could often cause that. Some of them are just constipated. It's something to do with having a bowel loaded with bacteria, creating who knows what. Again, flush them out, and if the brain fog's gone, then that's the easy answer. You can go from there. Another cause of brain fog, though, which is interesting, is disaccharidase deficiencies. We're hoping to publish on this soon, but there are a very small subset of patients who are low on all three, lactase, maltase, and sucrase when you biopsy them. And I've had a couple of patients who absolutely woke up by going on a low disaccharide diet. One woman turned up 2 months later and she looked completely different. I didn't recognize her, and she got a promotion at work. She looks like I woke up, everything changed. And that was kind of life-changing for me, because then I started investigating it further and looking for it further, but it hasn't been published yet, so we'll sort that one out. But brain fog is kind of one of those things that can have a few symptoms, but from your point of view, the easiest way to first try is to flush them out and see if it comes right. Now, stress is another one. So stress can be caused by GI symptoms, or it can cause GI symptoms. I'm not a health psychologist, okay? I tend to focus on the physical stuff because maybe it's a self-fulfilling thing, but if I can, you hear people say, oh, these patients with IBS, it's all psychological, or they're all a bit crazy, or, they're all wound up. And it's amazing the difference it makes if you can fix the physical symptoms. And a lot of these patients, some of them, they've got physical symptoms, but some of them have poor coping strategies. So therefore they're, turning up to you, falling apart. And if you fix the physical symptoms, they're an entirely different person. On the flip side of that, though, yes, stress can cause irritable bowel type symptoms in some people. I don't know. I still just remember our 5th year med school finals. We were all standing around in a miserable circle discussing what we were looking forward to after the final exams were finished in 5th year. And someone said, I just want to have a solid poo. And then everyone confessed they all had diarrhea. So there's no doubt that when you're at extreme stress, you do get loose bowels.
Yes.
And some people get abdominal pain and somaticize that. So you can't take that away, absolutely. But I tend to see people where the bowel symptoms are causing the stress more than the stress is causing the bowel symptoms. But invariably, there's some people with both. But it's very interesting because I tend to focus on finding the answer, and if I can't get anywhere, or if there seems to be a definite stress component, then clearly we can look, and health psychologists are very helpful there if you can find a good one.
Now, I'm going to put this question there. Probiotics, I've got a question here. Are they helpful?
Oh, you're asking.
You knew that was coming.
Look, I've watched probiotics with interest. I'm a total non-believer. Like I think they get 100% guaranteed to light and wallet. There must be out there are patients who benefit from probiotics, and so they'll never come to me because they're happy on them. But I tend to find patients have all tried them and not benefited from them. I'll go on too long if I start. Accordingly.
Now, in the Auckland region, I know you can't speak of nationally, but do you know if IBS can actually be, sorry, let me rephrase that. Within the Auckland region, in the public setting, is IBS accepted under public referral, whether that be by gastroenterologists or from the dietitians?
So it varies from DHB to DHB. One judges all their functional patients straight.
All right, John, I think the internet is spoken, and just with the sound issues that we now have, it's probably time to wrap up. So thank you very much for joining us tonight, and thank you so much everyone out there in the audience for joining us as well. So thank you again, everyone, and good night.